Just kind of some reference points also. My organization is a drug Medi-Cal system of care as well. So we have the region's largest drug Medi-Cal treatment system, residential rehab, detox, outpatient, a lot of medically assisted treatments now. So we've been doing a lot of integration with our health centers. Our CCC, Rio Casumas Correctional Facility, we started a program there some years ago where we did injectable Vivitrol, which is a naltrexone derivative that is injectable. That's why it's called injectable. And that was me injecting it. That medication was really amazing for people coming out of confinement, many of whom would relapse. That medication blocks alcohol and opiates for a month. So what we saw was that people, even when they use, nothing happens. And so we saw really a change in the arc of their recovery when they came out into the free world. They actually didn't go back, didn't relapse, didn't get violated again. And they very quickly stopped using if it didn't work. We call it our economic model, which is, why am I going to buy drugs if they don't affect me? So Vivitrol is kind of incredible. And then they would come to our health centers for a monthly dose. So there's the behavioral, there's the biologic, there's the social, and we try and wrap that all together. You're a whiz. Okay. And we're a specialty mental health system of care. In the state of California, you know, the drug treatment and mental health, these are forms of Medicaid that are then carved out from the pool and delivered through the counties. And so some of that work goes, or a lot of that work goes through the counties. So some of the work we have straight to the feds, some of it straight to the state, and then a lot of it straight through the counties. So you can imagine there's a lot of complexity. We have about 135 funding streams to manage as a result. The thing is, that sounds like a lot. It is a lot. It's a nightmare. But why shouldn't we do that if we can braid it all together and deliver something to people who walk through the door? That's what's important, not what's funding what they get. It's what they get. And so we have a sort of a devotion for them that turns into a perverse devotion to braiding huge numbers of funding streams. I am now not able to control this, but I'm half German. Control is a whole new thing. Yeah. Thanks very much. Okay. So just so you know what we've become, we're a network of community health centers. We have about 130,000 patients in the Medicaid program in our region. And our service area is Sacramento, Placer, and Amador. These are patients who are assigned through the managed Medicaid program, at least in Sacramento, and through other forms in other counties. We see about 400,000 or more visits, encounters per year, which translates to about 1,400 visits a day across our enterprise. And then our suicide and crisis lifeline right now has about 150,000 calls, chats, and text. So chat and text has become a big deal. And so we're getting a fair number of calls. It's going to double by the end of, maybe by the end of this year, as people they remember 988, they use 988, the counties are all transferring everything to 988. The sheriff won't even answer a mental health call and is transferring it. We've got a back line for them to 988. So when I say it's a big deal, it is quite a lift. But the honor here is that we can then become the front end. And the front end needs to change. I think we all know that our current first responder system is just really off-putting when people are in crisis. And so the honor for us is to try and figure out what is going to work for the people who are calling. A partial list of what we do has turned into this. Primary care, immediate care, that's walk-in care, specialty care. I'll touch on specialty care. So this is not just primary care, things that are specialties like our GI colleague here. Pediatrics, women's health. Every year, about a third, sometimes even a half of the babies born at Sutter Medical Center in Midtown are born to WellSpace Health moms. So when they built that hospital, I asked them to build a room into the labor and delivery unit so that one of our docs could be there at all times. There's a lot of stigma against poor people. And for the people we serve, the women we serve, having a baby is pretty amazing, right? They're bringing a life into the world, and They come from a background often of being seen as less than and treated as less than, and they are doing this amazing thing. And so we celebrate that. And one of the ways we do that is to make sure that we're there with them in the hospital and try and decrease the stigma. Health education, health change behavior. You know, and this is a weird thing. We've got like a very interesting Health and Human Services secretary in DC right now, if you haven't noticed. Don't forget though, this guy's in recovery. And it's interesting. He's in recovery, so he believes in recovery, and he says that. And this Make America Healthy Again program may sound wackadoo to a lot of people, but you know, for me, when I go to DC, my goal is to turn it into a health change behavior program. How can we actually help enable people? How could we take patients of ours even, who now are going to be subject to a work requirement, and have them involved in other people's care of their chronic conditions? A lot of that change management comes from underlying principles of motivational interviewing, actually the stuff that many of our drug treatment counselors do and are certified to do. You could replace heroin with Skittles, and you could have the same set of skills that you would use to treat someone with heroin, to treat someone with diabetes who keeps eating Skittles, right? And we have lots of examples of people coming in, and that's why their insulin levels are out of whack. Dental care. When we opened our first 20 chairs for children in Sacramento County, which was 2012-ish, we doubled the access for children in the Medi-Cal program in Sacramento County. So this is kind of what we're dealing with. It's strange. I'm actually the chair of the Managed Dental Advisory Committee for Sacramento County, which I never imagined I would do. But by doing that, we became one of the major providers in that space intentionally. And it's been a great honor. During that time when we started, if we needed a specialist, if there was some specialty dental procedure, our referrals usually went to Stockton. So there was not even the capacity in our community to take care of kids who needed specialty dental access, when in fact their mouths were really suffering quite a lot. And so over time, it's been wonderful to see the industry of specialty oral health move into Sacramento for the Medi-Cal, the Medi-Cal population, as we've grown a system of care that can support that economy. And so much of I see us as sort of a treatment industrial complex, which it's not kind of my upbringing. I grew up in the national health system, but you know, it's America. And so there's this sort of capitalist model, and that's what we're part of. We are a $150 million enterprise that's part of this economy with 1,000 employees, the 16th largest employer in the county, I think. So we're this thing, and that thing is focused on taking care of people who have very little or nothing. Care transitions. How do we facilitate care from one place to another? So many of the people we serve get lost in the cracks. They may not even get lost in the cracks, they get shoved through the cracks. I was doing an intervention the other day, and there was a young man, psychotic, in his parents' home, and the mobile crisis team was in the parents' home. And I said, okay, we need to get him to the hospital. I've arranged the admission, whatever. And the mobile crisis teams asked the chap, do you need help? Are you a danger to yourself? And he was psychotic, and he didn't really answer very well. And then he's like, no, I'm fine. And they said, okay. And they left. That was like 3 in the afternoon. 2 in the morning, he got admitted because we got police involved, got family involved. It was just ridiculous. So these care transitions are actually critical. And now we're sort of talking, I don't treat people typically, but I'm very interested in seeing these problems, because when I see these problems, I try and fix them with programs. And I have this amazing set of colleagues who ruminate about problems like that and fix them. Case management, active involvement in getting people their benefits, not just sort of lying in a hospital, wondering what they're going to do when they get out because they're homeless, but actually trying to find them housing, even trying to find them shelter. Birth and Beyond Family Resource Center, we've been very active in child abuse prevention or family development, and really reducing the incidence of referrals into child protective services. Much of that involves working in the homes, and we're one of 9 sites in the county that does this incredibly upstream child abuse prevention work through Birth and Beyond. I mean, we really have a lot to be proud of with this incredible network that's a bunch of us nonprofits working together. I think each of the 9 have 120 families. At any given time, we're going into the homes and checking that the outlets are covered and there's food. Because sometimes welfare workers will come in, see no food, and consider that neglect. So, you know, we've had to really adjust people's attitudes and make sure there's food, for example. Pharmacy, we have pharmacy. I don't know if I mentioned we have about 10% of the people we serve who are uninsured. So on top of that 130,000, there's another, you know, 13, 12,000 people who don't have coverage. Many of them are undocumented, and there's all kinds of new acronyms for talking about them and all kinds of amplified hate for them, but we serve them. With the adjustment to who can actually be on Medicaid, we're probably going to lose 20% of the 130,000. They're going to lose coverage. That doesn't mean we'll lose them. They will still come to us. We see them. And so the challenge and the juggle for us is how to continue their care when we've now got no coverage, no funding. We can't bill for them. But that's another story. Recuperative care, medical respite. I mentioned someone who's homeless in the hospital. If someone's homeless in the hospital, historically, you may remember the gurneys being dumped on Skid Row in LA back in late 2005. In 2005, we started a program with all the hospitals here where we said, rather than you dump the gurneys on the street down at Loaves and Fishes, which is not a shelter, it's a program that runs in the day to give people food, hence Loaves and Fishes, why don't we take those people for you? It turns out that people who are homeless, unsheltered, who have a medical condition, tend to stay in the hospital longer, on average about 21 days longer. And the reason for this is because the hospitalists, the providers, don't feel safe discharging them. They have a responsibility. Someone has a wound, it could get infected on the street, they're not going to discharge them. You know, someone who lives in a home or in a shelter, yeah, they'll discharge them. So the problem we were solving for was that 21 days. 21 days as an inpatient is kind of expensive. So we started with the premise that if we could reduce the number of days, that would be a reduction in expense, and maybe the health systems could help support a program with that reduction in expense. And we rented a suite at the Salvation Army, which was 18 beds in, I think, 9 rooms in one section of the Salvation Army. And we had 24-hour LVN and RN support. And we started discharging people to that program. And the doctors were able to discharge them, again, on average, 21 days sooner than they would have, because they had a safe, clean place. And then during their time with us, we started engaging them in care. Many of them obviously needed benefits to try and find housing. Some of them didn't find housing, and we were able to guess where we were? In the Salvation Army. So there they were already living there. Substance use disorders treatment, mental health treatment, primary care, engaging them with case management into the community so they weren't just lying in a bed for 21 days with cabin fever. Hospital social work doesn't connect to the community. It's about integrating within the hospital, which is great. But that care transition, this recuperative care, changed things. That program turned into 140 beds, I think. If you go down Stockton to Lawrence and Stockton, there's an old Safeway that we got, and we turned it into this massive palace of recuperative care. Does anyone here remember Greg Bunker, who started Francis House? Yeah. So that building's called the Bunker. I named it after Greg because we were mates and he died. And my staff thought that it was a military facility. Stephanie and the kids finally kind of, I told them that I wanted to name it after him, and it was very moving, and we had this big opening. But the Gregory Bunker Care Transition Center of Excellence down there on Stockton is a place where we do this now at scale with people nonstop, even when they hit the emergency room, if they don't need it, but they need a safe, clean place. And it's all funded, like the original program was funded annually by the health systems, and they used the savings of one patient to pay for a whole year for the program. So the scale is really interesting. Integrated behavioral health, psychologist, wants to integrate. Substance use disorders treatment. The effort, when it was started, was the Aquarian effort. It was very groovy, and it was the late 60s. It was started as a free clinic, like Haight-Ashbury Free Clinic in San Francisco, and they were started simultaneously, actually. And the Aquarian effort was a medical clinic for people who didn't have access, were not wanted at other sites. Veterans who were coming back before there was a network through the VA. A lot of veterans were disparaged and didn't get care, and a lot of them had become addicted because that's what happens when you have a war in the Golden Triangle. And so they came, and the Aquarian effort was the place for them. And I like to say that we're like an incredibly codependent organization. And so I know that my colleagues at the time said, gosh, it seems like substance use is somewhere in here. A lot of psychedelics, it was tie-dye heaven, and it was great. But so they started treating substance use as an outpatient. Then they said, gosh, we need a detox facility. They started a detox facility. We need a residential rehab. They started a residential rehab. So those are all still parts of our organization. We're actually funded to build about 200 beds on another property. We have a campus we're building right in Little Saigon, down Stockton Boulevard, where there'll be a 200-bed residential rehab facility, because we need to bring up the scale of access to those kinds of services. Medication treatment, assisted treatments, we have a lot more of that. 988 crisis receiving, we built a site downtown at 7th and H that's a 24-hour drop-off for people who are psychotic or intoxicated or both. And we started the first year just with law enforcement. It was actually a conversation with me and Chief Hahn at the time. It's about 5 years ago. We've had 15,000 visits in 5 years. And Chief Hahn and my conversation was something like this. Hey, Dan, you need to stop killing my patients, especially the ones who aren't white. And he said, yeah, you're right. And so we figured out that a lot of times it's the substance use, it's the psychosis that is so unnerving that it creates anxiety, and law enforcement are much more reactive. And that's often when implicit bias kicks in as well, right? People are nervous, they default to a set of beliefs that may be implicit rather than explicit. And that's when, Joseph Mann was being killed on Del Paso, and, these horrible situations were happening. So sure enough, they just started dropping people off. We made it a 3-minute drop-off. You don't need to know their name. You can call ahead to see if we've got a slot. And it just became a thing. We asked them to disarm people. Like if they had a knife, take it away. If they had a gun, take the bullets. But we have a place, it's like an amnesty box. You can just put your stuff in it and you'll get it when you leave. But the goal was just come on in and visit. And we give you a safe place. And if you need a referral, we'll give you a referral. This is really interesting. Have you all heard of Care Court? Care Court? Yeah. This is really a thing we're apparently doing as a state. Care Court was meant to engage people who have never been engaged. And it turns out that this facility, the Crisis Receiving for Behavioral Health, which we call CRIB, it's like a crib, and a lot of our clients call CRIB their home, their crib. We created this program and we started seeing people who had never been engaged in care. The police would say, wow, you're really psychotic, I'm going to drop you off here. And they had never actually seen a psychiatrist. They've never been in a program. Someone who is supremely intoxicated had never actually had someone say, do you think you have a problem? Right? And so it turned out that like 15% of the people coming in who were intoxicated chose the option before they went into withdrawal of going to our detox facility and getting on the med pack so that we could manage the withdrawal and trying a detox, which is fascinating, right? Now, if you look at the average age of all of those people, on average, it's 10 years younger than the average age of the people who would have come to our detox if we waited for them to have the insight that they had a problem and went to the county and said, hey, do you have a service for me? So when we think about Care Court, it's about being there for people and having a mitt that catches people in the right place. But then we're engaging people, in this case with detox, 10 years younger on average. Just think of the ravage, the hell that people go through in 10 years of chronic substance use. And we have far more opportunities for recovery as a result. So this crisis receiving site has been going well. We're building another really big one in South Sac. Do a lot of re-entry services. I think I'm only on like slide 3, and Colton, I will need your help again. Thanks. I said regional, and that's brilliant. Thanks. Oopsie. I said regional, and this is regional. The top right corner there is Roseville. Amador's out here, goes down to Galt. And so you can see we have these different kinds of facilities. At the core of it, there's 23 community health centers, federally qualified health centers with a bunch of other stuff nested in. All of them have a default integrated behavioral health practice. Behavioral health centers, care transition centers, rehab centers. When we started growing our organization, we had this free clinic. It was running along. And when we started growing, there was something like 80,000 people with Medicaid in Sacramento County who didn't have a place to go, didn't have a doctor. So where did they go? They went to the emergency rooms. So our model was to build that capacity for them. And then Obama passed Obamacare. And actually in 2014, another 120,000 people in our region became beneficiaries, thanks a lot, of Medicaid. So we had been growing, but we have, with our achieving regional health through high quality comprehensive care, with that mission, the goal here has been to stabilize a massive population. Does anyone want to guess how many people are on Medicaid in Sacramento County? 600,000. Wow, it's good. Yeah, just about 620,000 probably right now. A lot of people, a lot of people. So what are we doing for them? Because guess what? If we don't do something for them, where are they going to go? That crisis receiving site, 15,000 visits in 5 years. 4% of those we actually send in an ambulance to the hospital. We've changed the laws about where ambulances can go so they can drop them off there. Because it turns out that instead of 100% going to the hospital, it's 4%. So it's been re-engineering that system so that we leave the right places for the right people, but we bring a population in care. As I said before, we're really obsessed with quality. I call it administrative proctology, actually, because it's really quite invasive. But it's easy for me as the CEO to say, yeah, look at this. This is a lot of work. If anyone knows what the Joint Commission is, there's maybe 5% of federally qualified health centers in the country, and we collectively serve 33 million people. There's only maybe 5% of us have accreditation. We have ambulatory primary care accreditation, behavioral health accreditation. Our CCBHC, is accredited. And then we have 2 certifications that cross-reference the work we do. The patient-centered medical home means that if you come in to see a doctor and grandpa's outside and he's nodding out because he's on heroin, we're going to get him into drug treatment. The patient-centered health home says any door in healthcare goes to any service you need in our organization or elsewhere. The behavioral health home cross-references if someone comes in and they're intaking into our residential rehab and they mention that their kids don't have dental treatment, we will set their kids up with dental treatment. So you imagine that kind of cross-referencing and weaving those 2 systems together. The suicide hotline is accredited as a crisis center by the American Association of Suicidology, which none of you have ever heard of. You have to be that to be one of these crisis centers in the Lifeline. There are 11 in California. And also because we do chat and text, we're accredited for that by the International Council on Helplines. That is how we knew we could scale. When Deanna was talking about the growth, the embrace of the region, I could never have felt comfortable expanding my organization without working first on building the quality infrastructure. We literally took Joint Commission manuals and said, this is our quality infrastructure now. We will do it this way. And our recuperative care site, for example, we're now working with the Joint Commission on accrediting standards because we want to now give back to what is a new best practice? What would it look like if you regulate it? And so it's been the skeleton on which we've hung this remarkable organization that I'm just such a fan of. I banned the phrase safety net a very long time ago. Does anyone know what a safety net is? It's the thing the firefighters used to carry, right? Yeah. And so, we often hear things about the safety net, right? And so that we all know that means poor people getting help, right? So, does anyone, what's the first thing you think of when you think of firefighters holding a safety net? Someone's got to jump. Yeah. Yeah, you got to jump. It's often the nighttime. I always see the nighttime as dark, right? And you've got a building on fire and you're on like the fourth floor and someone has to jump into a blanket. And does anyone know why they don't carry them anymore on fire trucks? Because people would miss, or they were heavy and they dropped them, right? So it's kind of a problem. So when I think of a safety net, I I don't think of that as like the place that I would go for healthcare, right? I mean, I want to have access to a provider. I want a relationship with a provider or at least an organization. I want to know that I'm being tracked, that someone will call me. I don't want to know that every time I feel off, I have to wait till everything's on fire and then fling myself out of a window in the dark. That's just not my idea of healthcare. So we banned that in like 2008. So we call it our blanket of care. And you can see how much of what I've been talking about is we're replacing the safety net with a blanket of care. Now, I'm going to talk just a bit about the health center by itself. The free clinic, the Groovy Aquarian effort, became the effort. And that started in the late 60s. I think technically it finally incorporated in 1970. And what we saw was a very gradual growth across 10 years, where the free clinic just saw people coming in and basically an evening clinic. And then we applied to become a federally qualified health center. And then we were able to receive patients directly who had Medicaid and bill the state directly. And the feds have a whole structure for how you do that, okay? And then you can see some things happen and it grew, right? So in 2009, there were 3,000 patients came for the year to our free clinic. We became a federally qualified health center. And you can see that scaling of 44 times or so has happened in that time. Now, remember I said I was going to leave a little clue in the slides about when I severed my tenure? 2009, 10? Great. Who said that first? Okay, great. You can have my favorite red pen. There you go. Thank you very much. It's great. Yeah. So I didn't say, this place sucks. I had a reason that I just couldn't keep being the clinical director on a part-time basis. I had been writing this. The Congresswoman even adjusted the one of the laws at that time to include more federally qualified health centers in the network. And so our application was successful and this happened. And then we had Obamacare. In 2013, we started seeing people coming over under the initial beginning of the Affordable Care Act. And in 2014, you can see these tranches of patients coming in once the Affordable Care Act kicked in. Luckily, we had a lot of this going on. We had some infrastructure. We had processes, policies, procedures. We had a quality assurance program. It was stretched to the max, and we didn't even have enough facilities to see people. We built immediate cares where they could drop in and see someone briefly because they would never see their assigned doctor for like 6 months because there was no way we could see everyone within that time. But we built these workarounds to do that. And we built this blanket of care to replace the safety net. Now, I can't take credit for building all of this. One, because I've got incredible colleagues. And two, because we didn't just do it by ourselves. We started just aggregating. And I'm not predatory. I'm not one of these people who's really into merger and acquisition. But I did feel like if we were going to grow, why would we build it all ourselves if we had colleagues in the community who were doing it? If we had a system of economies of scale where we had an administration, for example, where we could bring people in who didn't. So we had the Aquarian effort, we had the effort. The Family Service Agency of Greater Sacramento was actually the progenitor organization. 1953, suicide prevention, mental health services. That merger happened in 2005. So when you think of like us coming together clinically, in 2005, the Family Service Agency and the effort merged into one organization. And that was an incredibly useful strategy. Instead of building our own, we brought in an organization that already had contracts, already had a system of care, and then our job was to integrate it. Healthcare for women, massive women's health program in the Medicaid population, down mostly on Hospital Drive in South Sac. That organization had 2 payrolls left when they approached me, and that was 2013. 2014, that was the end of 2013. 2014, they closed on a Friday. Everyone came to work on Monday, and our HR team was there, and they started working for WellSpace Health. So it was this continuity, and all of a sudden we had this ready-made, incredible women's health program that others were the pioneers for. Nirvana Health Clinics, this was an independent physician association, IPA, one of the for-profit intermediaries, and they realized that they were really crap at seeing patients. They were better at being a little plan, managing care, but they were really atrocious at seeing patients. Sorry if you're from Nirvana, but they actually just rang up and said, could you please take over our clinics? So if you live out in Roseville for a long time, you'd go along Roseville, and just before you got to Douglas, there was a big WellSpace Health sign because one of their clinics was right next to the highway there. So I didn't build those 3 clinics. I just brought them into the network. Sac Family medical clinics were around for a long time, mainly pediatric. And we incorporated those, we absorbed them in like 2016, I believe. And there were 7 of them. So you can see some of these tranches of patients came in that way. And what you also see is a partnership. It's not just us competing. We've never actually competed. I would say our competition is with ourselves to do better. And colleagues come in. Dr. Molina walked into my office at the end of 2017. He flew up, walked in, and I was like, oh my God, it's Dr. Molina. And he ran the Molina clinics here. And he said, you know, we can't afford to do this anymore. Could you please just take these 3 clinics? So he had to do a WARN Act. 60 days later, Friday afternoon, everyone lost their job. Monday morning, they came into work and they met with HR and started. So we just did these transitions, and we all came together. So my organization is sort of a coalescence of organizations. These days, we like to call it a confluence because we kind of see it all coming together. And someone thought that confluence would be a nice name because it's so familiar to everyone around here. But you can see all these organizations that we blended in over these years. I will mention the confluence, and then I think I'm going to run out of time because Q&A needs to come. We're all familiar with this confluence, right? The turgid waters of the Sacramento River meeting the supposedly aqua waters of the American River that have lots of mercury in them. But, you know, my organization, we call the things we do care streams now. There's sort of an obsession. We actually just made an LLC, and my colleague said, I came up with a name for it. I said, what's the name? It's flumen. It's Latin for river. So anyway, so there's this sort of watery theme going on, but that is something that defines our landscape, right? Is how water has defined our landscape, how these rivers come together. And really, for us, it is familiar because we've tried to define the landscape for people who need care. When COVID happened, the last thing we needed was people hitting the emergency room anymore. So we built our health centers into COVID centers. Some of them were just for people with COVID. We had a dental practice just for kids who actually had COVID, so that we could create a skirmish line out there in the community to stop people from hitting the emergency rooms, because that was needed for other people who were more vulnerable. And And it's much like the way the rivers flow in our region. We've tried to flow the needs of our patients into the right place over time. And the confluence is growing. There's going to be more about that in the coming year. When I met Deanna, I was the clinical director, and I had, in my practice over the years, been trying to blend things. And this is actually from an employee newsletter I sent out in 2012, saying this is where we came from and this is where we're going. Because we were always growing as an organization. There's a lot of education of all our new colleagues. The original organization was basically a free clinic, the little blue bubble. And then we had the drug treatment programs, detox, residential. So that's the orange bubble. And then there was the red, when we merged with Family Service Agency in 2005, we added all this mental health capacity. But then the goal was, how do we integrate that? And so we started that process of integration. And these images represent that integration, kind of roughly, approximately what it looks like. By 2009, when we became an FQHC, we had integrated enough to have quite a lot of overlap. And then by 2013, when the Affordable Care Act started getting ready, we had integrated quite a lot. We had an integrated behavioral health program in the core of our program, and we were scaling out that big blue bubble, which became very big, as you might imagine. This is sort of how we look at it now. That blue bubble is the FQHC, and then we have other parts of our care that either happen within the context of that funding stream, that place, or they happen outside. So mental health, that continuum, if someone is seeing their primary care doctor and they need a refill on their risperidone and they're stable psychiatrically, they can get it there. If they feel a little wobbly, they can see a counselor there. If they start decompensating and having a real mental health crisis, then we move them to the next level of care, which is sort of moving out of that sort of salmon-colored surfboardy thing, and outside the blue bubble into a specialty program that we have funding from the county to do. So as much as possible, we do everything within the big blue bubble in an integrated practice, but when people need to, we can refer them out into a more acute program, all the way out to our crisis receiving site, which is really coming in at the end. Then substance use disorders, same thing. Someone may stabilize and finally see their provider when, if they have medication, they get it from them. And specialty health also. Now, specialty has been tough. Federally qualified health centers are not specialty environments. They are primary care environments. So we've had to do a lot of negotiating to get the feds to let us do, I think, 14 different specialties at this point. Why? Because it's hard. Like, we rely on intermediaries, for-profit entities, to find us specialists in what's called the network, okay? And the network is magically provided to us by these people. Our doctors will make a referral, and then that referral will go to the network. Now, where is the network? A rheumatologist might be in Napa Valley. So that's 60 miles, 3 counties for poor people, We had at one point over 10,000 people with uncontrolled diabetes who were coming to us. And we were referring to the network for endocrinology to be seen. And it turned out the network just didn't have capacity. And remember, there's 600-odd thousand people on Medicaid in Sacramento County. So for me, bringing specialists in-house was important. The other piece was, when you have to go see a specialist, I don't think anyone ever celebrates when they're told, I need to send you to a specialist, right? I mean, it's usually not good. And so for me, what's the dignified way of having a specialist? I'd like you to see my colleague for your specialty visit. Not, I'm going to send you to a total stranger in Napa Valley in the network. I want that person to be someone who's familiar, because this is often shocking. And so what we've done is we've grown that specialty network in-house as much as possible. We share it with other health centers in the region when we have extra capacity. We've built relationships with different hospitals. Turns out there's like 20 rheumatologists at UC Davis. There's 20 at Sutter. But these networks don't contract with them because that would cost money. And so they found the person in Napa Valley. So there is, and sorry if any of you work for an IPA, but there's a reality to this where We don't pay for the right care, and people don't get the right care. It's really simple. And so that has been a problem we've been solving for a while. So here, as I mentioned, we have these for-profit third parties linking us to other partners in care, also the hospitals, and the health plans cover the cost of hospitalization. But some of the challenges with that yellow kind of network out there can be thin. And so we've tried to help fix it with added specialties within our organization. And we also started our own risk-bearing entity that's a nonprofit called the Nexus. And the Nexus spends money on healthcare. It's a nonprofit. We just put everything we get into healthcare. So we do have those doctors from Dignity. We do have those doctors from UC Davis because we spend all the money we get. We get a chunk of money from the health plan every month for each patient, and we spend 100% of it. And guess what happens when you spend 100% of it? People do better. So we're testing the waters now that we're at scale. The Nexus has about 22,000 patients, and we're testing those waters to see how it goes. Deanna just gave me the 2-minute mark. So here we go. Here's one outcome in testing the waters, that folks in the Nexus, when we started paying for all the specialty, up to 100% of the money we get, not having a 15% margin that we want to make to get another car, we were achieving regional health through high quality comprehensive care by demonstrating emergency room encounters dropping by 30%. People were less sick. We were wrapping them in case management, and we were just taking our money. Does anyone here work in insurance or medical insurance? There's a phrase they use. It's called a medical loss ratio. Yeah, and basically it means how much money you have to spend on someone's care, and they call it a medical loss ratio. If you've got $100 and you spend 85% of it on the person's care, your medical loss ratio is 85%. Okay? So the very language that people are using, if you lie in an infusion center and look at the machine that's putting chemo in your body, you're going to see cost center, number, whatever on that machine. The very language we use to care is language that is just horrific. So we don't use medical loss ratio. We call it our health investment ratio, and it's 100%. And it's kind of interesting how when you change that perspective, when you change that though with 22,000 people, you get a 30% drop in emergency room visits. Now, the danger we run is that if we announce that to people, please don't tell anyone, people are going to say, well, can I have that IPA? And then we have to take the hit. Now, since Deanna wants me to stop, I'm going to just put that out there with the Medicare Advantage program as well. Currently, the access to specialty in our community is the problem. If you're wondering if you're on Medicare Advantage, which plan should I get? You know, it's funny, my doctors keep bouncing around. The real issue we're having is a declining number of specialty specialists to access. And it's making it difficult to keep the cost of care. So you read the newspaper and it's like, well, United Health has severed their Medicare Advantage relationship with Sutter, or Anthem with Dignity. What's really happening is their medical loss ratio has gone up to a certain point. Is that 100%? Okay, I didn't say that. But that's what we're dealing with. And so we need to think differently about how healthcare. What's tragic to me is I think are there 2,200 counties in the country? This is just one. This really is not even a drop in a bucket. This is a tiny fraction of the people. We're going to lose 25% of our coverage of Medicaid shortly. And this is a tiny piece of an ecosystem. We need an adjustment of scale. We need, you know, with Medicare at least, there's regions that are covered. But with Medicaid, it's every county in the country has its own way of doing it. So thank you for letting me do this.
Thank you very much.
Let's try that one.
Thank you very much.
My question deals with substance abuse. Several years ago, we had a vote in Sacramento about even a needle exchange, and I don't think that passed. I think the sheriff department wouldn't accept it. My interest has been in supervised injection facilities over the years, and I know they've tried to do it under Trump 1, and they had trouble doing that. I don't know if Philadelphia started theirs or not. San Francisco had a secret one. Any possibility of thinking about SIFs here?
Yeah, so the one in San Francisco got shut down, and there's some wonderful film footage of it, filmed by our film professor colleague here, my partner, who filming that. The likelihood of us getting an injection facility here, it would be a useful complement to the range of services. When I talk about the crisis receiving, where someone comes in, they're highly intoxicated, no one's ever told them, hey, I think you need some help. It's along that continuum. And in some cases, people say, you know what, why don't you just start coming in and using in this place, and I'll make sure your supply is clean. And that's the first step for some people. And that's what these injection sites are. The likelihood of passing that in this community, in this climate, is zero. Maybe if we reconfigure the congressional districts, I don't know. But, yeah. So the San Francisco one was shut down. And San Francisco has really got a pogrom going on right now. The best one on the West Coast is in Vancouver. Yeah. And it was interesting. The mayor of Vancouver, in a wheelchair, with quadriplegia, invested in that because his best friend from school died skiing. And, his best friend from school died of heroin use. But the mayor had quadriplegia because he was skiing. And he said, we both engage in high-risk behaviors. I hit a tree, and I'm in a wheelchair, and everyone feels bad for me. My friend engaged in a high-risk behavior, and he overdosed and died, and everyone thinks he's a scumbag. So it was kind of an interesting decision on his part. Yeah.
Question over here. You've made reference to opioid use disorder and your approach to that, but more common in this county is methamphetamine abuse, which requires long-term follow-up care. And I'm just wondering if you manage any residential care facilities.
We are the only detox that the county will refer to for methamphetamine dependence because of our MedPAC. Our residential rehab facility, which is a modified therapeutic community, so that's a very psychosocial model, has a specialty stimulant treatment program within it. So we're actually experimenting for medication for methamphetamine dependence. Methamphetamine is still the biggest drug for us here. It's kind of getting overtaken by fentanyl, but that's because the dealers are cutting fentanyl into the meth. So meth is still the big drug, but we're getting a lot of fentanyl. But there's currently no methadone for heroin. There's no medication analog for methamphetamine. We're using stimulating antidepressants. And that stimulation in some cases is enough. I have proposed, and my chief health officer is willing to try this. If we're willing to give people one-to-one methadone to heroin, why wouldn't we give amphetamine to methamphetamine? Like, when you look at the ravage across the community and the children and the families, I'm not saying just hand out amphetamine, but let's say in a residential rehab, test the waters and see if something one-to-one, even temporarily. If you're willing to do methadone, it doesn't make any sense that you're not willing to do something else.
Okay. I wish we had more time, Jonathan. We'll just have to have you back.